Good evening, everyone, to this webinar by Mind the Bleep on GP training, becoming a GP, and everything about a GP by Dr. Zara Murphy, who's a GP. Just to let you know, we have got feedback certificates that can be provided, and that's once you've completed the feedback, which I'll post a link for. And Zara's also got the QR code on her slides. So if you have any questions, pop it in the chat box. But otherwise, I think we'll make a start, Dr. Zara.
Thank you. Right, so as Zamsel said, I am a GPST3. I'm working down in Plymouth. I want to make this as interactive as possible, so I'm not just talking at my screen. It's also the first time I'm using this software, so if you can no longer see my slides in full screen, please just pop your mic on and tell me. In the chat, are you able to just pop whereabouts, what stage of training you're in, whether you're a medical student, whether you're a foundation doctor or F3, F4, or whether you're in a different specialty altogether thinking of becoming a GP, just pop one short line in the chat and I'll keep an eye on that as well. Now, technology doesn't fail. This is what I plan on doing today. I'm going to talk to you a bit about my job and what my job looks like, what I like about it, what I don't like about it. Once we've gone through that, I'll have a little pause. You can ask any questions. And then we'll look at the GP training scheme overall and whether it interests you or not in terms of the training structure, how long it takes, what you need to do at each stage of training. And then finally, we'll look at the application process and how you can get into GP. And I will be open to questions as we go along. You don't need to save it till the end, just pop it in the chat. If you want to get my attention, pop your mics on and interrupt. So let's stay on this page for now. Okay, so the disclaimers. I applied for GP training in 2016 and started in 2017. Since then, things have changed in terms of how the application process works, and the sort of the GP requirements have also changed. Most of my slides are up to date because I made them last week looking at the website. But also bearing in mind when we come out of COVID, the pandemic, I don't know what going forward the application will look like. So all of this will be subject to change, but I can give you a rough idea of what it was like pre-COVID and what it's been like during COVID. I'm not part of the recruitment process. I'm here as a volunteer. I just thought it'd be good to speak about GP and to answer any questions and be honest about it. And if it is for you to then hopefully attract you to it, there's nothing in it for me. So that is my disclaimer. So as a GP trainee, I'm just going to check if anyone's put anything in the chat because I have to swap screens and I don't want to lose the slides either. So we've got someone finishing FY1. Cool. So you're thinking about applying, hopefully, or just thinking about your options. So I'm 80% through personal choice. It's really easy to go less than full-time in GP. You don't need a big reason. You could just say on your form that you want to go less than full-time. And I like to spread my hours. So I do 32 hours a week. I like to spread it over 4 days. Some people do full-time and spread it over 4 days. When you get to working in GP itself, you can create your own schedule. And so at the minute, my schedule looks like this. Mondays are my non-working day. I don't work. Tuesday morning is pretty much a full day. I have a clinic in the morning, a clinic in the afternoon, and I always have a home visit at lunchtime. Wednesdays I'll come back to because that's quite complex. Thursdays are similar to Tuesdays, and then Friday morning I tend to have a tutorial for a whole session, and then the afternoon they call it independent study, where I could be doing my portfolio or studying for my exams, or it's up to me what I do. I don't need to be in practice for that time and I don't have to justify that time. Wednesdays, the reason I say it's quite complex, it depends on where you end up in the country because each place runs it slightly differently. Wednesday tends to be GP teaching day. Some places do Wednesday mornings. Every Wednesday mornings it's your teaching time, so you will go along every Wednesday morning and then in the afternoon you're expected to be in clinic. You can move the independent study to the afternoon and have all of Wednesday off then. Well, not off, but not in clinical practice, but instead teaching in the morning and then studying in the afternoon. The way it works in Plymouth at ST3 is they do a full day twice a month, and that takes up 2 of the Wednesdays. The other 2 Wednesdays I would be expected to be in clinic, except I'm also doing a differential attainment role. So this the great thing about GP is there's lots of little extra roles you can take on. The differential attainment role is new to Plymouth. It only started this year, and it's essentially trying to support people who may struggle in exams for usually down to their background. So a lot of international medical graduates aren't aware of the exam system, or reflective writing might be new to them, and it's just supporting them as they transition into working in the NHS. And I've been doing quite a lot of that, and what they've given me for that is essentially 40 hours over the year, and I just extend training by a month, which I was happy to do. So that's what my current week looks like. I'm going to be changing it up from August, to give you an idea, where I'll make Mondays and Thursdays my full day, but I'll make them 10-hour days, and then have Friday morning the same, but then have Tuesday and Wednesday to myself, Wednesday for teaching, and Tuesday is my non-work day. So they can be flexible. Full time is 40 hours. There's no out of hours. I'll come on to that in a minute as well. And as long as your practice agrees, you have a lot of say over what time you're working. Now, I'm just going to switch back to the chat because I can't see it at the same time, and just see if everyone's with me. Right. So that's my week. What I don't like. So I thought I'd start with the negative so it can end on a positive. The training you're getting will vary depending on your supervisor and the practice you're in. So generally speaking, you'll be in at least 2 different practices during your training. And the first practice I was in, it was a much smaller practice, and it was more isolating than my current one. And my supervisor was sort of part-time, close to retirement, not really sure of the portfolio requirements. She was really nice and approachable, and she was supportive in the clinical sense, but when it came to keeping on top of the portfolio, we were both a little bit lost. And it depends on your personality. If you're quite easygoing and relaxed, you probably don't mind, but if you're someone like me who likes to be a bit organized and on top of things, it can be frustrating. You can change supervisors. I've not gone through the process, but it's better if you try to work it out with your supervisor. I would say, generally speaking, though, I've not heard any horror stories in Plymouth about breakdown in relationships. I think most people can make it work. The practices you're in can vary. So that initial practice I was in was a small practice. They were, when I say a small practice, I just mean they had the one branch. There were maybe about 5 partners and 2 or 3 salaried doctors, and everyone was part-time, and everything was operating in one little building. Whereas now I'm in a practice that's part of that is essentially the primary care network. It covers a huge area, and there's about 6 or 7 practices all under the same management and partnership team. And it does affect things because in this practice I've also got pharmacists, I've got the urgent care team is made up of the nurses and paramedics, and the services you offer do change. I didn't know what I would and wouldn't like in a practice until I joined practices. So it's good to get different flavors to work out what it is you do want going forward in your career. The other thing about GP, which can be a bit frustrating, is when you're referring people into the hospital or onto 2-week waits or into investigations, what a GP can and can't do does vary slightly between regions. So I'm going to pinpoint the Southwest as my examples because that's where I'm operating. But Plymouth is separate to Devon. And what I would say is the memory pathway in Torbay runs slightly better than the memory pathway in Plymouth, in that in Torbay, if you refer someone because you think they may have memory issues like dementia, they will go to a one-stop clinic and they will see a nurse and have their cognition tested, and they will get a CT scan, and then they will be booked in to see a doctor to talk about the results of both those tests. In Plymouth, the way it works is you see the nurse, you get your cognition tested, then you've got to wait to see the doctor because the nurse can't order a CT or an MRI. And then you see the doctor many months later, who then requests the scan. And then you wait many more months to see the doctor again to go through your results. So it's just a slower process. The forms you need to fill in can be different as well. And it's more the logistical side rather than the medicine. It's just working out, making sure the patient's on the right pathway. We do have a formulary, an internet formulary, that tells you what the pathways are, so you don't need to remember them all, and they're kept up to date. So if you're thinking, oh, I need to send this one off for a specific investigation, you can just look up what form you need to fill in and what pathway it goes on. The other thing to think about is when you're in training, especially, you might feel a bit isolated. If it's a small practice and there's no other trainees, or there's maybe one other trainee, but you don't overlap a lot with them. If it's a big practice where I am, there's quite a few trainees, and we also have 11 a.m. coffee breaks, and there's more of a social feel there as well. So that can differ. It's not so much the smaller practices are antisocial because they have their coffee breaks, but when you're going through exams or when you're going through certain things for the portfolio, it's good to bounce it off other trainees. But if you have good GP friends in other practices, you can always talk to them. So nothing is necessarily a negative. Everything's got a bit of a workaround. I don't like that there's no handover. So at the end of the day, if it's home time, tough, you've got a list of patients to get through. In theory, your supernumerary, your supervisor might take the work you've got left off of you, and you can go home. But in reality, what happens is you've got your patients, and you need to make sure that you've done all the referrals for them, you've done the admin for them, you've spoken to all of them, and you can't really push that work to the next day, because then it impacts your next day at work. So it is on you. You can't just hand over to the night team and say, right, I'm off now, there's this many people left clerking. You kind of have to stay late sometimes. There's a lot of clinical uncertainty in GP, and when you're new, fresh out of hospital, it can be quite frustrating, because you need to really think about what tests you're ordering, why you're ordering them, what information you're going to get, and what help that gives you. And the reality is, patients come with you and they don't have barn door symptoms, and they don't have sometimes you just look at them and you just think, oh, I don't know what's wrong with you. And that can be really uncomfortable when you're first starting out. But the more experience you get, the more you can go, you know what? I don't know what's wrong, but I know that it's not a 2-week wait for a cancer. So why don't I just ring you in, say, a month's time and see what's going on? And that takes a while to build up to that. And also you feel a bit like an imposter, like all of a sudden you think, I'm an ST1 or an ST2 and I've got my own list of patients, but actually I don't know what I'm doing. And that can be quite strong for some people. Okay, so what I do like is I do like the wide spectrum of illnesses we're getting through the door. Anything from, oh, got a bit of pins and needles in my hand, I don't know what it is, doc, to, end stage heart failure, palliative care in the community. You've got hypertension, you've got most things you see in the hospital, and you go see your GP about that, or say you've manage someone with a stroke and then you send them home. The GP is then picking up the pieces, working out medications they still need to be on, what care they might need, thinking what further tests they might need. And I quite like piecing that together. And I quite like thinking, especially with the elderly population, how can I try to keep them at home safely, especially when ambulance waits are ridiculously high and there's no bed flow, and there's no beds in the hospitals. So is it really the best thing for them to go and wait for 52 hours on a hospital trolley when I could maybe do something in the community first? So I'm thinking of a patient I saw with obstructive jaundice who had known reasons for obstructing, but he was becoming more unwell in the community. And the question and the discussion we had was, does he want to go in when there might not be a surgical intervention available for him because of his frailty and comorbidities? And if he decided not to, then how can we manage his symptoms in the community? Because I'm not going to reverse his obstruction. So it's thinking you manage a lot more in the community than you would maybe expect. And that's why communication is really good, being clear with patients about when to seek further help or what you can and can't offer, because you can't, not everyone will be suitable for all interventions, and it's being clear with them. And if you're not sure, that's okay. You can just say, look, I don't know what, the specialist will offer you. You can have a chat with them, and then decide, or if you don't think it's suitable, to even refer them, and then you have a good reason why. So someone with pins and needles wants an MRI and you don't think they need one, you've got to be able to sell that to the patient. And I also like being able to follow up the patient. So if it's someone that I was worried about a certain condition for, or someone I wasn't really sure what was going on, I like being able to say, you know what, I'll ring you in about 3 weeks, or let's do a blood test and I'll ring you and see how things are. And I feel like you don't get a lot of that when I was in hospital. You sort of see them, and then if they are having routine follow-ups, it's done by the consultants. But even then, they only touch on that particular condition. Whereas in the community, you get to start piecing people together and you get to work out, right, so this person is partners of that person, and actually they both had this happen in the past, and you kind of work out just from getting to know people over time what's going on for them. And that sort of stuff isn't in the notes. Like, you don't know that maybe their dog died because it's not in the notes or something, and you get more of that personal relationship. And there are still named patient doctors in most practices that I know of, and so there is that continuity of care. But again, it differs practice to practice. Some practices don't do registered, they don't register patients to a specific doctor, and then they end up talking to any old doctor. I like that a lot of it is clinical judgment as well, because we don't have instant tests we can do. It's not like I can say I'll do a blood test, I'll get the results in an hour, and then we'll work out what to do next. It's very much, if I want to do a blood test, I probably won't get the results till the next day. So how urgently do I need to get things done? Can I do this safely in the community while we wait for results? And it's a lot about making, using all that medical knowledge you have and making a decision without relying on investigations that you might be doing in secondary care. You also can watch and wait. So in hospital, you kind of, if you had someone and you weren't really sure what was going on, but you didn't think it was hospital, sort of, it needed hospital care, you would sort of say, go see your GP. And then sometimes in GP, we don't know what's going on, but we can use the watch and wait approach and see how things manifest. And with time, either get better by itself, in which case great, or with time it'll become a bit more recognizable as to what's going on. Okay, so before I go into the next thing, I can't see the chat, so if things are popping up, please do just yell out. So what I do like is obviously the lifestyle. Everyone talks about the lifestyle. When you're in GP itself as a trainee, you don't need to do night shifts, you don't do weekends, it's Monday to Friday. And the flexibility in work hours depends on you and the practice. So some people who are full-time might want to do 10-hour days over 4 days and have a 3-day weekend, and that's fine. For childcare reasons, some people might want a later start or an earlier finish, and they can accommodate that, especially as trainees. But also when you go into work as a salaried or a partner, you can choose, you can sort of lay out your terms. The caveat with the no nights and no weekends is that as part of training, and I'll come on to this later, is that you need to do some. So I think in ST3, my DNU wants me to do 36 hours of out of hours, and out of hours can be evenings and it doesn't have to be nights. Not all DNUs require that. So I will talk about that in a little more detail later, because it's not going to be relevant for everyone. But generally speaking, as a GP trainee, once you're in GP, you're not on an on-call rota. You are working more sensible hours and life's a bit more predictable, so you can make plans. And also being supernumerary, you get any leave you want. Now, in theory, practices might say, oh, give us 6 weeks notice. But if I message and I go, actually, I want next Tuesday off, and I did that, say today, they will more than likely authorize it, because I don't have to arrange a swap. I don't have clinical sort of, what's the word? So all my clinics are technically my supervisors there, and so obviously I don't want to leave anyone in the lurch, so I wouldn't do that. But in theory, if they haven't got anyone waiting to see me, and I'm not needed, then I should get the leave I will be wanting. And I don't factor into, oh, we need this many of doctors in the practice, because I'm not a salaried doctor, I'm not service provision, so I truly am supernumerary, and they won't go, oh, but if you're not here, we'll be understaffed, because I don't count in that sense. There's also the flexibility in the type of work you do. So I talked a bit about differential attainment. There's lots of scholar roles and fellowship roles coming out as well. And GPs, when they do end up qualifying, they do, some of them like to specialise or want to be a portfolio GP. So for example, I know friends who might say, I think one does 3 days GP in a practice, and then 1 day GP as an acute GP in our local hospital, and then 1 day as teaching for GP trainees. So that's a bit of portfolio GP going on. You get GPs everywhere now, so we're being recruited into A&E, into urgent care, gum, derm, women's health. There's also lots of fellowships and research. There's pretty much what you want to be doing, you can go off and pursue. So my plans will be 2 days in GP, your typical GP when I'm qualified, and then I'd like to do either 1 or 2 days in medical education, either with the university or with GP and trainees. But there's also new initiatives always coming up, and at the minute when you're qualified, you've got a 2-year fellowship you can get, which essentially pays you a session a week to do what you're interested in. And if that could be something like doing a PG cert or doing a diploma, or it doesn't even have to be that. It could be looking at well-being, it could be a QI, it could be whatever you're interested in. And they're really flexible. No one turns around and says that doesn't meet the criteria or you have to jump through hoops. So this 2-year fellowship program, it was only set up I think a year or 2 ago, and for as far as I can see, it's here to stay. And it is, everyone gets it. It's not competitive. There's not limited numbers. There might be for no, there's no limited numbers. So if you want to do it, you're pretty much certain to get it down here anyway. Right, I've talked quite a bit, and I have been trying to keep an eye on the chat. Right, so someone's asked, how many minutes can you spend per patient for consult as a trainee? So when you first join a practice, typically 30 minutes is what you get given. There's no rush to be quicker. I am still, my slots, it's a bit different because of COVID, and I just end up getting on average 20-minute slots because of the stage of training I am. But no one pushes you to be quicker till you're right at the end of training, because it's unrealistic to be that quick and get things dealt with. The exam portion, which I'll come on to, they aim for 12 minutes. And I think the main thing to remember, though, is that your list will start really manageable. So when you start in ST1, for example, you'll have 5 patients in the morning and 5 in the afternoon. And seeing as your sessions are 4 or 5 hours long, they're giving you a good chunk of time for each patient without you feeling rushed. And then they'll work, they'll increase that number. I'm on something like at most 10 in the morning, 7 in the afternoon. And I'm going to be CCTing next year. So I've slowly built up to that. And the idea is this time next year, when I'm a month away from qualifying, is when I'm hoping to be doing closer to maybe 16 per session. When you're qualified, it does depend on your practice. Some practices will want, so some practices split patient contact and admin time. And roughly speaking, the max that they should be expecting is 20 contacts in the morning and 20 contacts in the afternoon. Some people, some practices will include the admin time in your contacts. So you might only do 16 contacts in the morning, 16 in the afternoon, and then have 4 slots each to catch up on admin. Some practices, because they don't have paramedics, you'll get the stuff that saves you minutes. So you might have a really bond or UTI or a contraception chat, and that takes you less than 5 minutes. And then you'll have something really complex that takes a lot longer. The way it is at the minute, with so much complexity out there that you're handling, I think it would be unrealistic to be doing less than 15 minutes as a fully qualified. So my GP trainer, she has been working for over 25 years, and the more complex stuff, where she's known the family for years and years, still takes her 15-20 minutes. And if you've got 1 or 2 patients like that, that's fine. But if your entire list is like that, it can add up. But then I think with the experience, you get slicker and quicker, and you know what corners you can sort of be shaving minutes off if you know the patients really well. I hope that answers your question, but it's not like you hear, like, it's not 10 minutes like they say. Even the exams don't expect 10-minute consults. Any more questions about my personal experience before I move on? How does a salary progression work through training? So I was on the slightly old scheme where ST1 and ST2 were roughly the same amount of money, and then I had a massive jump in ST3 to essentially a registrar level that you would expect in a hospital. Now they're trying to even it out so that ST1 and 2 and 3 are paid roughly the same throughout. You also get less than full-time premier. You get GP, you get an added bonus for being a GP trainee. If you're in London, you get your London living wage. Essentially, at 80% as an ST1 and 2, I would have been bringing home. So if I was 80%, what was I doing? About 2,200. And now as an ST3, I'm bringing home about 2,600. Having said that, full-time trainees are getting over £3,000 that they're bringing home after tax. So it is well paid to a certain extent. And you can look up the exact salary and how they break it down online, because it also will differ whether you're working in England or Scotland, and it will differ whether you're working in London or outside London. And also my trust pays back my mileage, so that makes a big difference to me because I commute quite a long way for work. So if you're doing home visits or if you're commuting for work, that's quite a fair distance, you can claim back your mileage. So yeah, it's not that bad. Is becoming a GP the best for work-life balance? In my opinion. I'm glad you added that on because it will be my opinion. Oh, Julie, just to clarify, that's 3,000 a month. We get paid monthly, not weekly. And that's for 40-hour weeks. And I've never got that much because I've not been full-time. But my friends have reported they get just over £3,000 take home a month for doing 40-hour weeks and no on-calls at ST3. Sorry, Ahmed, is becoming a GP the best for work-life balance in your opinion? Now, I'm biased because I want to say yes, but essentially from what I've seen, the reason I chose GP is because when I was in medical school, I thought I'd never be a GP. I wanted to be obs and gynae. I loved obs and gynae. I loved women's health. I loved the idea of it. And then I started working in hospitals, and pulling all-nighters gets really tiring. And then the other thing I realized is constantly moving departments, moving hospitals, it's draining. And then to think you'd be doing that for 8 years full time or even longer to become at a certain level in your career, it really ground me, and I just thought I can't do it. I wasn't in love with any particular specialty to want to be doing that. And then also depending on what specialty you go into, like if you're going to A&E or intensive care, obs and gynae, you're on call during the nights anyway. So it's sort of like, when does life get a bit more easier? And because nights were a killer for me and I wasn't fully invested in a particular career, I decided I would much rather look at what would be sustainable for me long term. And then you factor in if you have kids, so I don't have kids yet, or if you want a family life, or if you want to buy a house, which career path would suit that? So for example, I was working on registrar. So Southwest is a really big deanery to cover as a hospital trainee. And I was working with medical doctors, registrars who were down in Cornwall Truro for maybe 2 years and then moving up to Bristol for 2 years. And they're in their 30s and they're close to being a consultant, and they've maybe got a 2 or 3 year old and they've got a partner, but they can't buy a house because they don't know whether it'll be long term. Or if they buy a house, they don't know if it's a long term house. And then when they get their consultancy, the consultant jobs aren't necessarily where you've been training. So then they have to relocate. And then you've got to pull your family to another part of the country, and it's like starting all over again. And for me, I was just like, I can't do that. I need to be able to set down roots. I need to be able to say, this is my community and these are my hobbies. This is where I like to go swimming. These are the walks I like doing. I like that, this is where I like to go shopping. It's, for me, that factor of life was way more important than a clinical career. And so, yes, it is best for work-life balance. For parents as well, we get a lot of trainees coming from other specialties. So I'm thinking this year we had 3 paediatric registrars join us because they got to ST4 and it just wasn't sustainable with having children and childcare, especially if their partners are also doctors. And you do get a lot more support for flexible working in GP training. Okay, I hope that answers your question. Then there was a question about any opportunities to increase your earning. Yes, a lot of doctors do SHO locums in the local trust. I did a bit of work with the local medical university as well. So what I would say is, if you're less than full time like me at 80%, if I then go pick up extra clinical work, they will ask me why I can't be a full time trainee. But if you're a full time trainee and you want to pick up extra work, go for it. You can't work as a GP or do the out of hours GP because you're not a GP when you're in training, but you can still be on the hospital locum banks if you want to be within hospitals. I know quite a few people who just did SHO jobs for the departments they rotated through, medical university work, or just non-medical work. I'm just thinking if there could be anything else. I think those are the common ones. Just keep an eye on your overall income and the tax that you then end up paying and the pension. Right, any difference between training in smaller towns versus major towns? Oh, depends who you ask. I did my medical training 6 years in London, and I felt like I had a really good training. I was exposed to more stuff, but I haven't worked there as a doctor, and I don't want to, because I think it was the stress I'm feeling now put times 100. But I feel like my money goes further in outside of London because I'm not worried about commuting costs. The living costs aren't as bad as London. You know, I feel I can buy a house more affordably down here than I can in London. I am biased because I love where I am now. I would say, so I did my F1 and F2 in Torbay, and then I decided to do GP training in Plymouth because Plymouth is sort of my local tertiary or big hospital. And the difference between the two is it's a small difference, but it's essentially that there are more services available in a tertiary hospital, but you're facing the same problems wherever you are. I felt like people are friendlier down here, but I don't know if that's because the people who stay down here really want to be here because of the quality of life, or if it was because it's a smaller hospital. Think about rurality as well. So for example, Cornwall is really rural, and some of your home visits might be 40 minutes each way. And also you might be dealing with a lot of stuff that you can't easily call an ambulance for. It's not unheard of. I did actually have someone, a friend of mine working in a practice in Plymouth, had a farmer turn up who cut his hand, literally severed a finger or something, bleeding everywhere. I was just like, oh, just patch it up and you get back to work. So I think it's more about the community you're serving and the community expectations. So yeah, the community will affect the sort of experience you're having. In terms of training, in theory, you're supposed to be getting the same training everywhere. I will talk about the training structure. But if you're thinking about the sort of experience you want with your training, I would say, I'm biased, but the quality of training I've had down here is really good. But the stuff I have outside of training is also really good. And I think you need a bit of both. The great thing about, I guess, major towns is you have more diversity. It's not very diverse down here. It is quite deprived. There's not a lot of culture in outside of, I think Exeter is it's the closest place where there might be a bit of culture. You don't get many gigs or concerts coming down this way, but it depends what's important to you. I will talk a bit more about that if you want, about experiencing things from a sort of minority ethnic background, if that's what you're interested in. I'm not an international graduate, but I also am aware of some of the struggles international graduates have. I've got another question about training experience in Plymouth. I will be going into that later. And then if there's a specific question you have, then let me know. But I will talk about the breakdown of what ST1 to 3 looks like in Plymouth. I have heard that rent takes about half of your monthly pay. Where are you renting? That's the question. So the rent will vary in the UK, and with the price rises and everything, it is getting unbearable for some. I was fortunate enough that I managed to buy a house with my husband in November. My mortgage is not that bad. It's not half my pay. So if you're renting obscenely, it depends what sort of lifestyle you want. If you're happy with a little pokey bed sit and paying, substantially less than a nice flat or a nice house. But yeah, rent. Also, be careful where you're renting from and who you're renting from, because you can get shafted, essentially. But that's slightly outside of being a GP. Timeline application process, yes, that's coming on. Exams and such, yeah, that's coming on. Which part of England would you recommend for an Okay, so let's continue, and that will hopefully answer some of your questions. And then if I haven't touched on your questions, especially around international graduates, remind me at the end. I haven't actually got anything formal about international graduates in this training, in these slides, but I've done a bit of work around it in Plymouth, so I can answer that at the end. But let me just move on. So the GP training scheme, if you do it full time, it's 3 years wherever you are in the country. I'm less than full time, so it's obviously taken me a bit longer. It's taken me 4 years, and that's fine. When I started, they had one system in place. So I did 18 months in the hospital, 18 months in the community. What that meant was I did in ST1 and ST2, I did 1.5 years in hospital jobs that were either, so they can be anywhere from 3 months or 6 months long. And then I did a 6-month post in GP, and then ST3, all of it is in the same GP practice. The new scheme is, I think, a lot nicer, and a lot more areas are having this scheme that they're calling integrated training programs. And the way that works is you do ST1 in hospital, all of it is in hospital, so you're on the on-call rota for whatever department you end up in. The specialties will be medical and relevant to GP, so you're not going to be on a surgical specialty, for example. And the way you get put into specialties, I'll explain how that works in Plymouth in a second. And then in the second year, you're in a practice for the whole year, but you might only do 2 days in the practice, and then 2 of the days you'll be doing in an outpatient department relevant to GP. So, for example, in Plymouth, you might do 2 days in sexual health, or 2 days in dermatology, 2 days in rheumatology, or 2 days in ophthalmology, and you won't be part of an on-call rota. You'll just do half your time in a practice and half your time in these outpatient departments, in clinics, learning what's useful for the community. And then your final year will be all of it in a practice. And I quite like that structure. Deaneries cover smaller areas as well for GP. So, for example, down here, if you were a medical trainee or surgical trainee, or even pediatrics, you could be down in Cornwall, you could be in Devon, and you could even be in parts of Somerset. And that's quite a big distance. So it's hard to then find a middle ground to then commute to all the places, and then you'll be constantly moving around. Whereas in GP, it's a much smaller contained area. So Plymouth covers Plymouth, and you will not be expected to be commuting outside of Plymouth like a huge distance for work, and you will not be asked to relocate during training. So all my hospital placements were in the Plymouth hospitals. Torbay is another GP deanery, and that covers Torbay, Torquay, Brixham and Paignton, and parts of South Devon, and that has one main hospital and 2 smaller hospitals that you could potentially do your training in. And again, everything is commutable, so you can buy a house or find a base and you can live there for 3 years. Some areas have a £20,000 recruitment scheme. There is some more information about this towards the end. Essentially, these are hard to recruit to areas, so to attract trainees, they offer you 20 grand. Sometimes it's for specific posts. So if you do a specific job in part of your ST1, for example, you will get this bonus. You get it as one lump sum in your first paycheck, so it gets heavily taxed. So then you need to talk to HMRC and get them to adjust your tax code. Some people don't like this idea because they think, why are you giving me 20,000? The reality is it's hard to recruit everywhere right now, so it's not necessarily a rubbish area. But when I was applying, for example, Plymouth was a TERS and the Lake District, and probably because there's not as much draws down here in terms of diversity and city life, and also like it's rural and not everyone wants to be somewhere rural. So you get that lump sum. The caveat, you read the small print, because the caveat might be that if they fill those spaces, they take away the offer. Or the caveat might be if you leave training before you've completed it, you will then owe them the money back, depending on how much time of your training is left. So there's pros and cons to it. And I think a few other specialties are beginning to do that. I think psychiatry now have it as well. When you apply for training, you can either do your 3-year GP training scheme, or you can do an academic fellowship. Now, the difference that I read about is that if you just want to be a GP, your bond or GP trainee, you apply through Oriel, and I'll show you a bit more about that in a minute. And you apply nationally, that's what you're doing. But if you want to be an academic GP trainee, you've got to apply to specific deaneries. I'm not an academic trainee, and I'm not 100% sure how their training program works. It obviously runs with the rest of the GP program, but there will be time when you're doing an academic project. But I have got links, so if you're interested in that, you can look at it yourself. In the 3 years, you will be doing a portfolio, and I'll go through a bit more about that, and there'll be 2 exams. Now, driving is essential. You can start the GP program without having a driving license. You can start GP, you can be in the GP training program and not have a car. It makes life a little bit harder, but you can manage it. The problem is when you're qualified, a lot of your contracts that you'll be getting from practices will require you to do home visits. And if you're not driving and you don't have a car, then they'll expect you to somehow find a way to do a home visit. You're not exempt. So if you can use a bus, so in London, it'd be easy. You can use a bus, you can use the underground, do your home visit. When you're somewhere in Devon and you don't have a car, it's hard. You know, even the public transport system's not reliable, and it's not that frequent, and it might not even be going where you need to go, and taxis are expensive. So just bear in mind, driving you will need as a GP, maybe not in training, but definitely at the end. Okay, so we talked a bit about the training structure split into 3 years. You will have an educational supervisor who stays the same in ST1 and ST2, generally speaking. And this supervisor you'll meet up with every 6 months, even when you're in the hospital. And you will do your GP placement with this education supervisor. When you get to ST3, your education supervisor will most likely also be your clinical supervisor, because you're in their practice. At each stage, so in ST1, you only do a portfolio. You can't sit any of the exams in ST1. The portfolio requires, so the numbers changed because of COVID, but essentially you do regular reflections. You do you need to do some mini cases, and you need to do some case-based discussions. And the numbers are not taxing. They're a lot less than they were pre-COVID, and they're also a lot less than you would have to do if you were a medical trainee. You have to do a quality improvement activity, so like an audit. I think if there's anything else you need to do, I think that's all you need to do as an ST1. You have to do your safeguarding and you have to do your BLS, but you've got to do that every year. In ST2, the portfolio requirements are roughly the same as ST1, but you also are now eligible to sit the applied knowledge test. Now, I've got another slide on that, AKT, and I'll talk about that in a second in terms of how much it costs and what you do for it. And then in the final year, you've got a bit more to do on the portfolio. So I've got to do a prescribing assessment, which is a new thing, and I have to do a leadership, and I have to do something else I have to do that is new. But it's not big chunks of work. They just they are a little bit tick boxy, but they can be done, and they can be done in a short space of time. And you also got to sit the RCA, which I will also talk about. Now, before I talk, oh, that's handy. I've got the exact breakdown there. Let me just check if anything's happened in the chat since then. Okay, there's been a couple of questions, but what I'll do is I'll finish this section and come back to that, so I'm not going off on a tangent. So in terms of portfolio, we use 14 fish. It's so RC, when you become a trainee, you become an associate in training of the Royal College of GPs, and you have to pay a fee. Now, I can't remember what that fee is. You pay it every year. It's a few hundred. It's not cheap, but it's also not ridiculous. I think it's 400 a year, maybe less. And that will also give you access to 14 fish. 14 fish is it's where you upload all your evidence and your portfolio. They also have teaching modules, and they also have exam modules that you could pay extra for, and that's covered by the Royal College fees. You also need to make sure you have your GMC fees every year paid. And the other thing is your defence union, or the most GP training programs now provide you with the defence union cover. I think those are the subscriptions I could think of. I don't think there's anything else you need to pay for. In terms of buying your own equipment, when you're in training, the practice will give you the equipment to go on home visits. You are expected to have your own by the time you are salaried, but only the basics, like a blood pressure, pulse oximeter, a stethoscope, if you want a tendon hammer and otoscope, but you can claim that all back on tax. So in ST1 and 2, reflections, a personal development plan, and it's just 3 things you like to do, and mine are really basic. I think this rotation, my personal development plan was to sit my AKT and do a QI, and I matched them up with my portfolio so they're easy to tick off. At the minute, you need, in a year, 4 mini-CAXs, 4 CBDs, but if you're doing 2 6-month rotations, that's 2 per rotation. You can't do 4 in one and none in the other. You have to do a certain amount per rotation. Quality improvement could be really short and easy, like an audit. An MSF, so multi-source feedback, you need 10 responses from teammates about whether that you're professional or not. Your 6-month supervisor meetings are 6-month supervisor reviews, just to make sure you're ticking all the boxes. And every year you do safeguarding and BLS. And in ST3, you've also got to do a little project that shows leadership. You need to do something, you need to do like a Excel spreadsheet to show your prescribing, and whether you just look at the prescriptions you've done and whether you can improve the quality of them. It's not looking at mistakes, but just like things like, have you documented the indication for that medication? Have you documented when you're reviewing that medication? Have you made it clear what instructions are for taking the medication? It's a little bit tick boxy. Now, urgent and unscheduled care, it depends where you are in the country. So the Royal College says you do not need to do out of hours. This can be done as part of your day job. So you, for example, you can be the duty doctor or working with the duty doctor. So in theory, every GP practice has a duty doctor every day who takes same day sort of appointments, and that can meet that requirement. In Plymouth, they want you to do a certain number of hours with the out of hours team. It was Devon Docks, they've just lost their contract. And because it can be hard, especially with COVID and not having enough doctors out of hours, to find time to go out of hours, they're not as strict with it, but they still want you to try if you can. And I think it's something like 12 hours in your ST1 or ST2 when you do GP, and 36 hours when you're in ST3. Which if you do 4-hour shifts, you can spread it out nicely. If you do a full day, 12 hours, you could do it in a short space of time. You take that off your clinical work in GP. So you're not working extra in a sense, you're just getting the experience. If you can't get the time because of lack of shifts, you can just do reflections and do duty doctor stuff. So that can vary depending where you are in the country. And also 14 Fish, that's also what you use to, so all of this is uploaded on 14 Fish, and you also use 14 Fish to sit your RCA exam. So the first exam you will come across is the AKT. I'm just checking the chat. Okay, so the AKT, you sit it in ST2, you can sit it in ST3. It's made up of 200 questions. It takes 3 hours, 10 minutes. It's done in those driving centres where you probably did your MSRA or your driving test. It's multiple choice. There's no essay answers, and 80% of it is testing your clinical knowledge, 10% is testing your stats knowledge, and 10% is testing your admin knowledge. Now, stats is usually quite basic. It gives you a graph you might see in a research paper and asks you which of these statements about this graph are correct. So it's just making sure you're familiar with interpreting graphs. The admin, no one ever teaches you this stuff, but you can pick it up through, there's lots of really good YouTube resources, and it's just about the legal requirements of having a practice, the health and safety law, because when you're a GP, if you're a GP partner, you're a private employer, so you need to know the rights of your staff, and you need to know the legal stuff around record keeping, health and safety, and it's a bit dull, but it's information you can easily get and remember. The Royal College of GPs has a free question bank with over 3,000 questions. They are questions used in previous exams. So in theory, you don't need to be paying above and beyond for extra courses. Some people do. You have 3 opportunities to sit in the year. So you can sit it in January, April, or October. You're allowed 4 attempts, and they recently put the price up and it's now 470 quid per attempt. They say something like 99.7% pass within 2 goes. It can be a tough exam, especially for international doctors, because it's not testing knowledge, it's testing your clinical process. In that, what you've got to read the question really carefully, in that what they're either asking, what is the initial thing you will do, or what is the gold standard, or what is the safest thing to do. So if this was a patient in your room, how would you manage it? And I used the NICE CKS guidance, I used RCGP, and then I paid out of pocket for another exam bank, and that was enough. And yeah, so that's the AKT. It's not the worst exam I've heard of. Like you can pass it. It is very much, you can pass it on your first go. If not your first, then your second. I only know one person in the last 5 years who is having a 3rd attempt. The RCA. Okay, I'm just going to have a drink of water because I've been talking quite a bit. So the AKT has been there pre-COVID. It has stayed the same during COVID, and it probably will keep going. The RCA is new. Before COVID, there was something called the Clinical Skills Assessment, where you'd go down to London, and it's a bit like an OSCE or an ISCE, where you had stations, and each station would have a simulated patient with an examiner, and you would consult them in a certain time frame. And you know, it was all done in one day. But obviously with COVID, they had to change things up. So they introduced the Recorded Consultation Assessments, RCA. This, at the minute, will be running until September next year. After that, they're talking about bringing in some sort of hybrid or options. So either something they can do over Zoom, or something where you can opt to do the RCA or the CSA. I'm not sure. There's talks, but nothing's official. At the minute, so what I will be doing is I will have to record on 14 fish, 13 patient consultations. They can be telephone calls or they can be video recordings, and they need to be in 12 minutes. So essentially the examiner starts listening after you've introduced yourself and got the consent, and they stop listening at the 12-minute mark from there. And you need to cover you have to cover certain topics. So obviously nothing intimate. You can't examine you can't record and submit anything intimate, like, you know, back passage exam or a breast exam. You can't do that, but you can do a consult, for example, about breast pain. But what they will specifically want, so there's 13 categories and you need to hit them. So you need to make sure you do one with a sick child, one about mental health, one about an older adult, one about women's health, one about men's health, and I can't remember the 6th one. So, a long-term condition. And then the others are up to you. So there's 6 that you definitely have to hit, and then the others that are ones that you think are good. So you record them in practice. You can record them anytime up to 6 months before you submit them, and you have to have consent of the patient, which is done through the system, and that's what they're accepting at the minute. There's pros and cons. I've obviously not sat the CSA, and I haven't sat the RCA yet either. But the pros are that you get to pick your cases and you have more influence over what you're submitting, and you have more time to get it done. The downsides are patients are not your typical. If you had an actor, then they have a script. And as long as you do their ICE and you get all the pertinent points from the script, you've passed. But if you've got a patient, they don't follow a script. And sometimes you think you've done a great job, and then right at the end they go, oh, one last thing. And you think, no, don't bring something up now. So there's pros and cons. But essentially it's assessing your consultation skills. Okay. I can't remember how many attempts you get. And it is quite steep per sitting. Right, that's my check-in point. So I think the next bit was talking a bit more about, oh, what was the next bit talking about? I'll remember in a second. But let's just look at some questions. So someone's asked, which part of England would I recommend for international doctors? I don't know, is the honest answer. Everyone's got different experiences. I don't like cities. Some people really want to be in a city. Some people want to be where they have a large community of a similar background. I would say work out what's important to you. Do you want a community around you of the same cultural background or the same faith? And then look for cities that offer that. And or if that's not as important to you as having a work-life balance or quality of life, say you've got a particular interest or sport that you're into, look for an area of country. The thing is, you'll always hear pros and cons. It's what you make of it. And if you decide that, like for me, for example, it wasn't a big deal that there wasn't a big community around me from my cultural background, so I'm happy down here, but then I know colleagues who aren't happy because they want to be around people of the same community. So it's down to what you make of it. Someone's asked, anatomical knowledge from med school isn't the best. No, is mine is fine. Anatomy is not a very big part of being a good GP. It's patient communication is the biggest thing about being a GP, because if you can reassure your patient and explain things to your patient, they won't keep coming back with the same thing. And if you don't address, so we have ICE, I'm sure a lot of you know about ICE. If you don't address your patient's concerns or their expectations, they will keep coming back. So a lot of GP training is about communication skills. Also, when I do my consults, I have the NICE guidance open, have the BNF open, I have the local formulary open. I'm Googling things all the time, you know, like I'll do my neuro exam and then go, oh, what muscle did I just test? And I'll do a quick Google to work out what my dermatomes were, what my muscle testing was. It's not about being able to label every single thing. It's more about being safe. And so if you don't know where the latissimus dorsi is, fine. Just, are you safe? Have you documented clearly your clinical exam and your clinical reasoning and what your plan was? What clinical subjects do you come across most commonly on a day-to-day? Aches and pains. A lot of aches and pains. I'm just thinking, so a lot of aches and pains. You've got to get good at your contraception and menopause options, a lot of social issues, mental health, a lot of like complex comorbidity, frail people. So you might have someone, you know, older people having falls at home because they're on like 3 antihypertensives. You know, people with type 2 diabetes, it's long-term management as well. So people with management of type 2 diabetes and hypertension. Occasionally you get something that might be quite exciting. I had a new diagnosis of ulcerative colitis, as in I didn't know it was ulcerative colitis, but he clearly had inflammatory bowel disease and he was clearly having an acute flare and he clearly needed to go into hospital. And I also have had renal colic because of renal stones, and I'm not saying that they're common, but you do get a good mix. Right, I know we're coming to time and I know there was a little bit more I wanted to discuss. Someone's asking a bit more about rotations. What I'm going to do is just whiz through the last few slides and then I will talk a bit more through your questions. So, application process. If you're thinking about applying, you need to have a GMC license, you need to be eligible for full registration. So essentially, if you're F2, you might be applying before you've, you might be applying before you've gotten your full license, but as long as you're not looking to fail F2, you can still apply. And they say you need to be able to drive or have a way of going on home visits. I don't know how closely they screen that because I had a lot of people in my cohort without cars and not driving. It's not mandatory, even though they say it is. At this stage, you do one application on Oriel for, when I say 4 nations, so that can be England, Scotland, Wales, and Northern Ireland. And what you do is they rank everyone that's applied, and you then get given your choices based on where you come in that rank. Now, obviously, if you're really high up, you're likely to get your first one, but don't be disheartened, because if you want to go somewhere that's not as popular, like Plymouth, and you're lower down on this national ranking, that's fine, because there's not many people coming to Plymouth, so you're likely to get that. Now, they do a round one in, I want to say, November time. Oh, I got a timeline on the next slide, which is good because I can't remember. But you do a round one quite early on in the autumn, and then they give those jobs out. Then they re-advertise for the round one with any jobs that are left. And that's to start in the following August. You can defer your entry by a year, so you can get your place and then defer it. And then once they fill the places for August starts, they then do another round recruiting people for February start the following year. At the minute, so let me talk to you about my experience. I had to sit the multi-specialist recruitment assessment, the MSRA, MSRA, in one of those driving test centres. It was multiple choice, clinical knowledge, nothing specialist. It was very much being able to recognise an acute situation, knowing your A to E's, seeing common things, and you do that, and then you get ranked. Now, when I sat it, the top 10% were automatically given their first choice. Anything below that, you were asked to attend a face-to-face. So I did my face-to-face, and the first portion of it, we did 30 minutes, a bit like SJT, where they give you, it was paper-based, I had to write, and you got 2 or 3 questions saying, no, or was it just one? It was 1 or 2 questions saying, rank what you would do in this situation, and then write a little paragraph explaining why you've ranked the way you have. And then I had to do like an OSCE style where I had 3 consultations with actors, and it was about communication, not my knowledge. So, someone wants to make a complaint, or someone is nervous about a procedure, and it wasn't assessing what you knew, but more about how you handled things in your communication skills. Because of COVID, what they've now done is you only have to do the MSRA, I wrote it the wrong way around, but they've now introduced 50 SJT questions. So as well as the clinical questions, you now also got to do the SJT questions, the situational judgment test, where they give you a scenario and you've got to rank from the options which you think is best down to the least best. There is no other way to boost your score, so there's no requirement. They don't ask for evidence, like they don't ask for if you've got a master's or another degree. They don't ask for audits or certificates. They don't ask for portfolio. So if you have all that stuff, great, but it won't strengthen your application. It's based purely on the MSRA and the SJT portions of the test that you do. So the MSRA, 97 questions, 75 minutes. And also you've got the 50 SJT questions in addition now because of COVID in 95 minutes. I don't know whether they're going to keep this format going forward or if they're going to revert back to the pre-COVID where they do the face-to-face scenarios. And it was 3 cases I did face-to-face. Now the timeline. So if you want to start in August this year, you would have applied in November, you would have sat your MSRA in January, you would have known by March where you whether you got the post and where you were going. In terms of how you can hold posts, I'm not an expert, I can direct you to the website that explains it. Some people apply for 2 or 3 specialties, but you can only hold 1 post at a time. There is obviously upgrades and other things. I don't know the ins and outs of it, but there is a useful guide that I've linked at the end that explains it in more detail. If you want to be starting in February next year, you can apply from July. You do your MSRA after you've applied, and then you get your job offers by the end of September. This is last August. Was it last August? Yeah, last August competitive ratios. Yes, right. So it can vary year on year. Some places are more popular than other places. So London is obviously really popular. So what these numbers mean is for every 1 place, you would be competing with 3.2 people if you wanted to do London. I'm down in the southwest. So for every job place, you'd be competing with 1.5 people. You know, if it's 1.1 like in Yorkshire and Humber or in Wales, then essentially it's not that competitive. Now, it will always say it is a competitive process. It is competitive in that you need to fulfill the requirements, but they are so desperate for doctors that if they have a job, they're not going to say you can't have the job if you fulfill the requirements. These are some useful links. I will share these slides, but the GP National Recruitment gives you a breakdown of the oral process, how you hold an offer, how you reject an offer, how you upgrade offers. The eligibility criteria is also there, and then TERS in a bit more of an explanation of what jobs are recruiting for TERS. When you rank jobs, so when you get Oriel, when you get onto Oriel and you do your application, you rank regions of the UK you'd like to work in. And then once you got given a region, you rank, so I had to then rank hospitals or like specific areas I wanted to work in. Is it in that way? I'm just wondering if I had to rank Southwest and then had to rank like Plymouth, Exeter. Yeah, I think that's the way it was. Or if things have changed, you might have to rank deaneries. So, for example, Plymouth or Exeter, North Devon or Torbay. I don't think it's that way. I think you still rank by HEE areas, and then you rank again for which specific ones once you've got an area, and then you rank so certain posts you rank the jobs that you want. In other posts you just get given the jobs. It again varies where you go. This is the feedback. Now I'll leave that on your screen while I go back and look through some of the questions that have been coming in. Thank you for coming. If you don't have a question, feel free to fill in the feedback form and you can go. If you want to stick around and ask questions, I'm happy to stay and answer. Now, just going back. So, ST1 rotations, which one would be most useful for GP? I'm of the opinion that the broader, the better. So things that will help you understand the referral pathways and what hospitals can offer. So A&E, acute medicine, or a medical job is really good. Pediatrics, maybe a bit of obs and gynae. I don't think things like ophthalmology or dermatology are necessary or ENT, because you could pick that up in your day job, and sometimes the hospital stuff, like for example, ENT, you will never refer otitis media up acutely, or the stuff that I manage like tinnitus, ear infections, you won't learn that in ENT post because that's mainly a surgical post. Ophthalmology, again, you're not going to dilate eyes and look in the back of eyes in GP. And same with dermatology. If you've got a suspicious lesion, you'll be sending it up. You won't be getting your dermatoscope out and be biopsying it. So I think the broader the better to understand the community pathways. Having said that, if you want a nice life, ophthalmology is a nice life. 9 to 5, no one calls as a junior. I did mine more strategically. I did what I think would benefit the most. So I did healthcare of the elderly, which I think is really good to do, because a lot of what you do is elderly population and managing comorbidities. And I did pediatrics because I hadn't done that in F1 or F2, and that was really useful. And I did psychiatry, community psychiatry. And again, that was really useful as well, just to learn what was in the community resource-wise, what was, what the thresholds were for referring from GP and what patients could expect once they were in the system. So I found that really useful. But I'd also done A&E, acute medicine, obs and gynae. And what else did I do? And another medical job in F1 and F2. So I felt like I had a good base. So I would say go broad rather than specific, and think when you're on those posts, think about the pathways and what could have been done in the community, and at what point were they referred into the hospital, and then what has the hospital done that couldn't be done in the community, and when you've discharged them, what do you expect to continue in the community? Next question, how stressful is it being a GP? Because of the broadness, I think So it depends what stresses you out. I find the workload is much better than when I was in a hospital job because I can control it a lot more. In terms of the breadth, it's not about, you pick it up with time. You get faster and faster. You get to go, oh, that's hypertension stage 2. I'll start them on this, and this is the Ramipril, for example, because they're the guidelines better for the really common stuff, and that comes with time. The biggest thing is knowing what needs referring and what doesn't. So if you go, I don't know, so I've got someone who has weird pins and needles in weird places, but not fitting a particular pattern, but only pins and needles. And I've done the blood work on him and it's all normal and he's young and he's healthy. And I've gone, you know what, I don't know what's wrong, but I don't need to investigate. So we're just going to sit on this and I'll check back in with you in a month's time. As long as you're safe and you've done what is appropriate, that's fine. The other thing is that I didn't mention, in GP, you debrief with your supervisor. When you first start, you go through every single patient you've spoken to that day. You go through your decision making, and that's really useful because you learn a lot from your trainer as well. When you get further into ST3, you might only pick up 1 or 2 of the patients that go, oh, I wasn't really sure about that. Can I just double check that with you? But initially, you talk through every single patient, and that's how you learn about the pathways. You learn about what you could and couldn't do. You get more confident in not testing things. Also, you don't need to remember it all. It's like you'll have a computer screen, look it up on NICE-CKS, look it up on the local formulary. So as long as you know that's not, say, a 2-week wait. So by 2-week wait, I mean you haven't got a 60-year-old with new iron deficiency anemia, which needs a 2-week wait, colorectal. You can say, oh, well, we have time. Let's think about this logically. What information do I need? And sometimes, it might take a bit of time for you to go, oh, I need to refer you. And that's fine, because not everything is evidence straight away. It's just about being safe. I don't find that part stressful. I find it stressful when I have lots of really complex patients back to back. But then I also have a really nice weekend. So it's how you deal with the stress. I much prefer having a reliable work schedule to a hospital rota. Based on what do they rank applicants? Your multi-specialty recruitment assessment score is purely based on that. They don't look at anything else. Do they offer pre-allocation for those needing to stay in an area for health issues like with FY1s? I don't know, look at the website, but I know that you can submit exceptional circumstances forms. I don't know what they do and don't consider. And I don't know how much weight they give it, but yeah, I think because people have caring responsibilities or other life things going on, there is a form you can submit, but I don't know how much weight they give it. You'll have to look that up, I'm afraid. Lots of people thanking me. You're welcome. Okay, how many people are still here? I'm happy to answer questions. I know I didn't touch on international medical graduates, so I don't mind talking a bit about that here. So we have a large international medical graduate cohort because we've been a hard to recruit to area, and we've now also recruited international GPs into some of the training roles to support those trainees. I think the biggest thing is the communication side. So we're doing a lot of support around communication in terms of, supervisor says, I need a bit more detail in your reflection. And that could mean anything. And so some international doctors think they need to be quite literal, write down every observation. And actually it's not that. What they're saying is we need a bit more introspective reflection. And if it's a different way of thinking for you, because you're not to do reflections in your medical training, it can be a bit like being lost. So we do a lot of work around portfolio and portfolio expectations, a lot of work around communication skills, a lot of work around exam techniques. And we're not perfect, we're building it up. And one of the things we're now looking at is when you apply as an international graduate, the deanery will be your tier 2 visa sponsor. When you've then qualified, you need to find a practice to be your sponsor, and not many practices in Plymouth are set up to be sponsors, and it's about a 2-month process and it can be a bit arduous. But what Cornwall are doing is the CCG takes on your tier 2 sponsorship, and they then put you in place practices. And that's one of the things that Plymouth might consider. So we know it's a bit of an issue and we're working around that. There is, well, it depends. I mean, there is communities to be found. I've been doing monthly socials, family friendly socials. I won't be continuing that, but there is also local doctors in Plymouth who, for all doctors, do a lot of socials in the southwest, but they also gear towards international doctors. They put on a lot of courses about life in the UK, life in Plymouth, and that's open to all specialties, not just GP trainees. So that's a good way to meet lots of other people. Okay. Any questions? I think Samsung really wants you to fill in the feedback, please, and that is how you will get your certificate. Job adverts say we welcome doctors from an underrepresented group in this organisation. Does this apply to IMGs in general, or will you be prioritised if you are? I don't know about prioritisation. I guess what they're trying to say is, part of me is being cynical, right? What they're and by underrepresented, it could be essentially your ethnic minority, it could be your sexuality, it could be a protected characteristic that they don't have a lot of, and so, you know, an older graduate, for example, there's certain things that they're saying they're just trying to attract people. I don't think it gives you a priority. They're just saying apply and we will consider it. But no, there isn't a prioritization, or what do they call it? Can't remember. There's a term for recruiting certain characteristics. It's not that in the NHS. They're just saying apply and we will look at it like we do with everything else. Okay, there's still 35 of you. All messages, right. Can IMGs apply all year round or all postings start by August? Okay, so let me show, well, it's on the slides. You can't apply, there are application windows. You can't apply outside those application windows. So the first lot of application window is from November through, I say that, let's have a look. Let me bring it back up. Application window, here we go, is November through to March, and that's for an August start. The other time you could start is in February, and that application window is July to September. So those are the only application windows to get onto a training program. I hope that answers that question. You're all welcome. Just seeing if any more questions trickle through. If you just want to leave, then I know, or I don't know if you're waiting for me to end it, but I don't want to end it if there's still questions coming through. So I'll give it a few more. Where can we get?
I think at this point, what we can do, if there's any other further questions, they can always post the applying to GP article on Mind the Bleep. And then I think we can probably just best take it from there.
Yeah, okay. I'll just answer the last couple of questions and then I will end this, and then you can pop any questions on Mind the Bleep on the Facebook event group or wherever, and I will get back to you if I can. I will share the slides with Mind the Bleep and hopefully they will then pass it on. How best to prepare for the MSRA? I did a lot of questions. Where did I do those questions? I think I used past medicine, but I always find past medicine to be a lot harder than the real thing. There's a lot of companies out there, Aurora Medical, eMedica, you know, big companies that do a lot of work around exam prep. I would say choose one that you think suits your style and just do lots of questions. Okay. Right, so thank you everyone for coming and for engaging. I will end this here. I'll share the slides with Mind the Bleep. Any further questions, pop it on the event, either on Medall if you can, or over on Facebook. I will go through and answer what I see. If I miss it for whatever reason, Mind the Bleep can answer, and if they want to reach out to me and ask me, I'll then answer through them. Okay, so thank you everyone for spending your evening with me. I hope you've done the feedback. Bye from me.